Welcome back, everyone. I hope you had a nice little break. Thank you for joining us for our final session for today. I'm really grateful for Equip and their fabulous speaker for being here. So I'm going to pass it over to Jessica Hickman to introduce Equip and our speaker.
Hi, everyone. Good afternoon. I'm Jessica Hickman, Clinical Partnerships here at Equip. I will just briefly introduce who we are before welcoming Jessie to take over the presentation. But if you have not heard about Equip, we were founded in 2019, really with a mission to ensure that everyone with an eating disorder can access treatment that works. So on that note, we are virtual by design to eliminate geographic and logistical barriers, and are partnered with most major insurance companies to really ease the financial burden of treatment. We virtually deliver evidence-based eating disorder care and really build on modalities like FBT, CBT, and DBT, so patients can achieve lasting recovery at home while still living their everyday lives. Our care plans are highly individualized, and patients can bring their village to treatment. So we can really help build an environment around them that's conducive to recovery and protects against relapse. And with that, all of our patients are matched with a dedicated multidisciplinary care team that includes a therapist, a dietitian, a medical provider, and a peer and family mentor. And patients engage with these care team members through one-on-one sessions, in between session messaging, and unlimited weekly groups and skills classes. And importantly, we treat patients of all ages in all 50 states with any eating disorder. And because of our individualized approach and wraparound support, we can work with patients of a wide array of acuities, really across all levels of care, as long as the patient is medically stable. And if you'd like to learn more about Equip, our resources, and appropriate referrals, please don't hesitate to reach out or visit our website at equip.health. I'll also leave my contact information in the chat. And just moving right along, I am excited to introduce our speaker for today's presentation, Dr. Jessie Menzel, who is our VP of Program Development. She is a licensed clinical psychologist and former associate clinical professor in the Department of Psychiatry at UC San Diego, where she founded the Pediatric Eating Disorder Program. Dr. Menzel also has 15 years of clinical and research experience in the field of eating disorders and has worked with individuals of all ages across all levels of care. So please welcome Jessie.
Hi, everyone. Thank you so much for having me. I am here today to talk about ARFID, probably my favorite subject. As Jessica mentioned, part of my background is founding a pediatric eating disorder program, which really, when I started it back in 2014, we built it to treat ARFID. We were seeing sort of an increase in these patients presenting to our partial hospital program who were coming in not with traditional eating disorder symptoms. They were often very, very young. And so this was right around the time when the diagnosis got published. And so I really spent a lot of my career kind of growing up with the ARFID diagnosis and really leaning into it heavily to learn more about it, to figure out the best ways to treat these patients and meet the needs of these patients, particularly during a time when we had like no research on it and nobody knew what to do to treat it. So this is my favorite thing to talk about. I'm really glad to be here today to do this. I'm hoping that I can focus pretty broadly on ARFID across the developmental spectrum. So I'll touch on some things that are particular to children and other youth. And also I want to make sure we include adults because they're often left out of the ARFID conversation, but are very much a part of this diagnosis. So to begin, I just want to disclose that I have no conflicts of interest. I'm not affiliated with any, how do we put this? Oh my goodness gracious, why is this word escaping me? But basically I have no conflicts of interest with entities that would be an issue. And so we can begin to talk about ARFID. So for those of you who aren't familiar, ARFID stands for Avoidant Restrictive Food Intake Disorder. I'll just be using the acronym today. And I'm hoping that we can cover, like I said, a pretty broad swath of info from both the diagnosis to how we assess and identify it and some issues with assessment, as well as treatment. So kind of pretty broad strokes introduction to how to begin to treat these patients. So I'm sure most of you have heard of ARFID. I'm sure you're coming in with some sort of background or orientation to the disorder, but I just want to give sort of a brief 101 kind of background on ARFID. So first, ARFID is considered to be a restrictive eating disorder. So meaning that we are talking about an eating disorder that is founded in either not eating enough total food, so you're not consuming enough calories to help you meet your energy needs, or by not eating enough different types of food. So you're restricted in your variety. So maybe you leave out whole food groups, or you only consume a minimum amount of total foods. And this restriction is not driven by weight or shape concerns. And I want to just kind of elaborate on this a little bit more, because I think sometimes there's a narrative around the fact that somebody with ARFID can't have body image concerns or can't have body image distress. And I want to take a second just to say that, like, that's not what's intended here in this diagnosis. I mean, we all live in a world that is surrounded by diet culture, that is surrounded by weight bias. And so none of us, eating disorder or not, are immune from having beliefs related to what an ideal body should look like. And none of us are immune to body dissatisfaction. We can be dissatisfied with our weight or shape or how we look and still not meet criteria for an eating disorder. So the same is true of our patients with ARFID. What's meant here by this rule out part of the criterion is simply that it's not the body image disturbance or the dissatisfaction with the way one looks that's driving the restrictive eating behaviors. So rather in ARFID, the restrictive eating behaviors are motivated by something else, which we'll talk about in a minute. Also, hot off the presses, the first genetic study related to ARFID was just published earlier this year, finding that ARFID actually has a very high heritability estimate. So we're thinking that these early estimates coming out of a pretty large twin registry from Europe is that ARFID is almost 80% heritable. And I think this is notable to talk about, because this is almost on par exactly with what our genetic estimates are for anorexia nervosa. So we know that anorexia has a very high genetic loading or genetic component to it, and it looks like ARFID may as well. Demographically, ARFID is a little different from our other traditional eating disorders, traditional in quotes, like anorexia nervosa or bulimia nervosa, in that there isn't as much of a gender disparity. So right now, these estimates will vary based on which population the research comes from. So if we pull these estimates from data collected from more of a traditional eating disorder center, like a partial hospital or a residential program, they're still much more biased towards like cisgender women. Whereas if we pull these numbers from more community samples, we get a much more even gender distribution. So right now, data suggests that ARFID can be just as common in boys and men as it is in girls and women. ARFID also does not have a weight criterion, and we'll talk about that in a second. So you do not have to be underweight to be diagnosed with ARFID. However, depending on the age that it presents for treatment, we do notice that the bulk of patients who tend to be weight compromised tend to be younger patients, and actually that the average adult with ARFID tends to not be weight compromised. They're sitting at a weight that's appropriate for their age and their height and for their history. And finally, the average sort of age of diagnosing ARFID is in the teens. And so this is a little bit of a surprise, because I think usually when we think ARFID, we think young kids. But that's probably, again, more of like a bias in the data and a bias of like where we've studied this diagnosis in the past. So this estimate came from, again, a large community, like pediatric sample that found that the most common age to diagnose ARFID was around 13 years old. So a number of thoughts about why this might be. This might be sort of the point at which impairment from ARFID becomes most notable. So this is the point at which maybe people are presenting for treatment or diagnosis of their ARFID, even though they've been struggling for years and years and years. So right now we're looking again at an average age of diagnosis that's about on par with anorexia nervosa. And while we don't know a ton about our long-term outcomes with ARFID, we still have yet to build up that arsenal of research looking at patients with ARFID who are recovered or who are many years out from recovery. But we do know some things, which is that ARFID, at least again, left untreated or that it persists into adulthood, has a very high likelihood of having a psychiatric comorbidity. So almost half of all patients will have at least one co-occurring lifetime psychiatric disorder. And we also know that the disorder does appear to be stable in the absence of treatment. So there's one study in particular that looked at a group of, I believe, Swedish adults who had been diagnosed with an eating disorder at one point in their life. And this team followed these patients, I believe it was 15 years sort of post-diagnosis. They had to go back and kind of retroactively see like, okay, did this patient actually have ARFID versus something other eating disorder? And what they found is that our patients with ARFID continued to struggle and be sick if they had not received treatment. And their sort of long-term trajectory or long-term outcomes looked very much like their partners with anorexia nervosa. They had, for example, higher rates of like absenteeism from work or were more likely to drop out of school and again, continue to be struggling with their eating disorder into their adulthood. So this is something I talk about a lot, particularly when I am working with young children, actually, or when I'm talking with pediatricians, because I think often eating concerns in really young kids are often dismissed as, so, well, they'll grow out of it, or it's really normal for a kid to be finicky at this age, or just give it time and, things will get better. And I do think it's important to point out that now we have data, actually not from this adults, but from like toddlers and school-aged kids too, that suggests that there is a group of kids who presents with eating concerns pretty early on in life, where those don't resolve with time. Yeah, we have a portion of kids that, if they're picky or finicky, they do kind of grow out of it, but there is a significant portion that don't. And so I think this is really important to emphasize that this isn't like a wait and see type of disorder. This is a disorder that will persist if we don't intervene. So let's talk about ARFID a little bit more specifically and what it is. So as I mentioned, ARFID is a restrictive eating disorder that is characterized by problems with either volume or variety. And we mentioned already that these are not restrictive eating behaviors motivated by a desire to lose weight or a desire to change the way one looks, but rather they're motivated by other things. And there's sort of three main categories that we talk about, categories of motivation that we talk about with ARFID, or I like to call these sort of the mechanisms or the drivers of the eating disorder behavior. So these three mechanisms that we often focus on are a fear of something bad happening after eating, or a lack of general interest in food. So someone just doesn't get a lot of pleasure from eating and they don't have a strong drive to eat, or they're very selective in their tastes or their preferences. Now, to meet criteria for ARFID, you have to have that restrictive eating behavior that results in one of the following outcomes. So I often get asked a lot, well, what differentiates just like a normal picky eater from somebody who has ARFID? These are the criteria that are responsible for that differentiation. It's very possible to be a pretty picky eater, but still grow just fine, and be able to find lots of different foods to eat, even if they all tend to be pretty similar. And, you can still go out and function in the world. You can go to birthday parties, you can go out to eat, you can have relationships. However, if your picky eating results in one of the following, then we're dealing with ARFID. So going back broadly, that range of restrictive behaviors, there are four again, you only have to meet one of these criteria. You don't have to have all four, you don't have to have a mix, but just one of these criteria is what differentiates ARFID. So ARFID can either result in weight loss or a failure to grow. Again, only a subset of patients actually lose weight with ARFID. Many are at a weight, again, that is healthy for their body. In young kids in particular, though, another really common growth-related outcome that we see is actually just failure to advance in your growth curves. So this might be a patient who doesn't lose weight, so they don't have that like little cliff that they drop off on their growth charts. But this is rather a patient that flattens out. And during kind of critical growth periods, so particularly in the time leading up to the start and continuation of puberty towards the end of it, we should always see that growth curve getting to climb. It's a lot steeper at the beginning, but eventually it starts to taper off. And so a patient with ARFID is one who, well before that growth curve is supposed to be finished, they start to flatten out. So their weight stays the same, they're not losing, but they stop gaining height and they aren't putting on weight during a time in their development when they should be. Nutritional deficiency is the second way to meet for ARFID. So this is having actually like a documented vitamin or mineral deficiency, something like anemia. But in the field, we also see patients with nutritional disorders like scurvy or rickets. There are other more serious nutritional deficiencies that can also result from ARFID. But this is, I'll just say like in my practice, this has been something that I don't see quite as often. I'd say more likely I see patients who we would deem to be at risk of developing a nutritional deficiency. In our culture in North America, so many of our foods these days are vitamin and mineral fortified. So for example, if you have a kid with ARFID who eat cereal every day, they're probably not going to be vitamin or mineral deficient because there's so many vitamins and minerals that we fortify our cereals with. Same thing with our breads. So this one is probably, you're not as likely probably to see like a diagnosable nutritional disorder like in the blood work for your patient. But based on the contents of that patient's diet or the way that they eat or the types of foods that they eat, they might be headed towards a nutritional disorder at some point in time if they continue to eat like they do. So often I'd say just in practice, a lot of providers tend to interpret this criteria as more risk for nutritional deficiency as opposed to having a diagnosed nutritional deficiency. The third way to meet for ARFID is having a dependence on enteral feeds, which is tube feeds. So either an NG, NJ, or a G tube, or oral supplements, something like an Ensure or a Boost or Carnation Instant Breakfast. So again, threshold kind of that we use, I'd say just sort of like in lay practice is about 50% of the diet is our threshold. So we're looking for patients that, more than half of their calories are coming from liquids instead of solid foods. Another way you can think about this is that if, you had a patient who like lost access to their liquid supplements, would they be able to continue to grow and eat enough food to meet their nutritional needs? This can kind of help you tell the difference between somebody who maybe just prefers a supplement versus somebody who's dependent on it, meaning they just don't have enough other foods or aren't able to tolerate solid food volumes enough to be able to grow or maintain their weight. And then the final way to meet criteria for ARFID is simply just if your eating behaviors cause problems in daily living. So you may be on track weight or growth-wise, or you may be maintaining a healthy weight for your body. You may not have any nutritional deficiencies, and you may be able to eat 100% solid food, but your ARFID very much impacts your quality of life. So what this looks like often in young kids is an entire family's life begins to revolve around their child's ARFID. The way that they grocery shop, they have to buy whole separate types of foods for their kids. They have to make separate meals for their child, or they may even have to make multiple meals a night to sort of like hit on that one variation of food that their kid will eat. They often can't go out to eat at restaurants because they can't find something that their child will be willing to eat at restaurant, or because their child is too fearful to eat foods that haven't been prepared at home by one of their particular caregivers. And it has to be a specific caregiver. So like I'll only eat if I know that mom prepared the food, and I won't eat if dad prepared the food or if grandma prepared the food. It also causes problems in socializing. So we have ARFID kids who often won't eat in the cafeteria or with their friends because they're embarrassed about the way that they eat, or because they have fears related to eating in groups or out in public. They can't go to birthday parties or sleepovers because they won't be able to find anything to eat at the birthday party or the sleepover and will go hungry as a result. I often, it's a great metaphor that a clinician, one of my colleagues, told me about, that she uses with her families and with her patients, which is that another great way to kind of distinguish between somebody with ARFID and not, is that if you deny a patient access to their preferred foods, how do they respond to that? Do they eventually find something else to eat? Ooh, I've knocked over my water bottle. Do they eventually find something else to eat, or do they just choose to not eat? And this is likened to, I guess, pandas. I guess pandas I only eat bamboo. And if you remove access to bamboo from pandas, they starve to death. They don't find anything else to eat. And that's often what these ARFID patients are like. So in the absence of their preferred foods, they don't push themselves to try something new, or their hunger isn't enough to sort of drive them to eat. They just don't eat. They prefer to go hungry. And so often these patients, like, they can't do things like go to camp, and they can't sleep over, or they can't travel, because they seriously risk not being able to consume food and therefore losing weight. In our teens and in our adults, often this problems in daily living show up as they can't date because so much of dating revolves around food. A lot of embarrassment and shame because, as adults, we're supposed to be able to eat vegetables, and we're supposed to be adventurous eaters, and we can go try the Ethiopian restaurant, or, we can go eat sushi. And someone with ARFID may really have a lot of discomfort being in those situations. And so they miss out on a lot of socializing opportunities. They can't just go with their coworkers to happy hour after work, because again, they may not be able to find anything to eat, or they might be embarrassed about what they're able to eat. I had one of my patients I worked with about halfway through treatment. His dad was like, I think my brother has ARFID. And he's like, he is 35 years old, and he lives by himself. He's not married. He stays in his apartment all day long, and he eats 3 things, and he's incredibly depressed, and he's really socially isolated. And that's, I think, one of the biggest complaints we often see in our adult patients is they're like, I can't connect with the people around me because I can't connect around food. Now let's talk a little bit more about what ARFID then actually looks like. And as I mentioned, there's often a stereotype, I think, of thinking of ARFID as just a disorder of picky eating, but it goes far beyond that. And there are sort of these 3 central drivers that lead to the restriction. And even though these drivers actually aren't a part of the diagnostic criteria, they are something that I really encourage you to familiarize yourself with, because these will be things that are incredibly important to determine how you end up treating ARFID. Because I often will tell people that I feel like no 2 of my ARFID patients are the same. And there's definitely similarities, but for example, how I approach treating a patient who has selective eating is very different from how I approach treating a patient who has fear of aversive consequences. So to give you a little bit more of a description of what these 3 presentations are, selective eating due to sensory sensitivity is that presentation that looks the most like picky eating. So these are the patients who have a very narrow sort of range of foods that they eat. They might eat 15 or less total foods. They may cut out or exclude full categories or food groups. So really common ones to exclude are fruits and vegetables, but also proteins are another one that these patients particularly struggle with. They also may be really particular about food. So, they may have, let's say they eat peanut butter, and that's one of their 15 foods that they eat, but it has to be a very specific brand of peanut butter. And they're so sensory sensitive that they can tell if you've switched out their brand. So just by tasting it, they know that this is Skippy peanut butter and not Jif peanut butter. For another kind of place I've seen a lot of this particularity is around the breading on chicken nuggets. So chicken nuggets are a really popular ARFID food, but often It's the breading, it's the texture of the meat that can really vary quite significantly between like a McDonald's chicken nugget and a Chick-fil-A chicken nugget and a Dino nugget. And they're very sensitive to those variations. And if that variation is off, they won't eat it, even though it's technically a preferred food. I had patients who, if they eat bagels, the bagel has to have a certain kind of degree of char on it. And when I was working in a partial hospital setting where we fed our patients, this patient was so particular that his dad would come in every morning to make his bagel for him to eat in program, because it had to be made in a toaster oven and it had to have a certain kind of char, and the butter had to be like totally melted and you couldn't have them see any butter. And so that level of rigidity, you can see how that very quickly causes stress for a person or for their family. Those preferences might be based on taste, they might be based on texture, it could be based on smell, but also the color and the temperature of the food as well. Fear of aversive consequences is a pretty unique group. This is a group of patients where they have this fear of a bad outcome happening after they eat. The ones we see most commonly are fears of vomiting, fears of choking. But another one that I think people don't immediately think of, but I think it makes up a pretty significant portion of these patients, are fear of allergic reactions. So this might be a patient who doesn't actually have allergies, but thinks that they're sensitive to foods and therefore fears having an allergic reaction to those foods. Or they know somebody who had an allergic reaction and now they're scared that, well, what if I have an allergic reaction? But also patients with actual documented food allergies that become so nervous or so anxious about their eating that they begin to exclude foods that they actually can eat, more for the possibility that the allergen could have been in them. And these are patients that I've on many occasions see wind up on an inpatient unit because they're so concerned about allergic contamination that they've even stopped swallowing their saliva. That somehow in the act of breathing, that allergen particles have like drifted into their mouth. And if they swallow their saliva, then they'll ingest that allergen. So they become really dehydrated really fast and wind up on an inpatient unit. The third group is a group of patients who just lacks a general interest in eating, in food or in eating itself. So this, as I mentioned, presents with a bit of like a hedonic angle to it, that they just don't enjoy food. So I'll talk with a patient and tell like, all right, tell me your favorite food, the one that you like more than any other. And then they'll tell me their favorite food. And I'll say, okay, tell me how much you enjoy eating that food. Like scale from 0 to 10, like 0, ugh, I don't want to touch it. Please never give it to me. 10 being like, oh my gosh, I love this. I could eat this every day. I can never stop eating it. And the patient will say like a 3. And that's their favorite food. So food is not like a really rewarding thing for them. And patients with this brand of ARFID, particularly adult patients, will say like, it is a chore to eat. Like a hallmark kind of signifier of this presentation is I have to force myself to eat. And often these patients will eat a pretty decent variety. They're not restricted in that sense, but they just don't have that strong innate drive. They don't get strong hunger cues. They tend to get full really quickly after eating just small amounts. And again, there's not a fear here of gaining weight, and there's not a desire to lose weight. It's just food doesn't interest me, and I don't have the strong physiological drive to eat. So it's a chore. I have to make myself do it. Often in this group, you'll see as well, I think just kind of in general, a lot of sort of functional GI symptoms. Again, that early fullness, a lot of abdominal pain, bloating, kind of a general sensitivity to the overall volume of food that makes them very uncomfortable and reluctant to eat or interferes with their eating as well. So I've put these 3 in like a Venn diagram, in large part because one of the things I want you to walk away with from today's presentation is to actually not think about these 3 kind of categories of ARFID as categories or discrete or like separate entities. Our research is really clear now that our ARFID patients, actually probably more of the rule than the exception, is to present with more than one of these sort of categorical presentations. So it's very common to see overlap. That someone, for example, who is a picky eater might also have specific fears related to eating. Someone who has specific fears related to eating might also have a lot of like volume sensitivity and may lose their appetite or their drive to eat. Someone who is selective might also just in general, like perhaps they are selective in part because food isn't rewarding to them. And so they can't find a whole lot of foods that sound good to them. So it's really common to see some overlap. So for example, abdominal pain is a symptom that's really common between our fear patients and our lack of interest patients. Having lots of stomach complaints. Like one of those fears can be fear of pain, fear of abdominal pain. So we might see overlap in those symptoms there. General anxiety around eating is a symptom that's shared by all three of these presentations. So even though, for example, our lack of interest patients may not have a specific fear, or our selective eaters aren't like afraid of the foods that they eat, there's anxiety about trying new foods, anxiety about whether or not they'll like that food or whether or not it will be really aversive for them. And our lack of interest patients, anxiety around that stomach discomfort. A really common thing to see in these patients is, for example, not an overt fear of vomiting, but a fear that they might vomit if they push themselves to eat too much. Being afraid to try new foods is also a symptom shared by our fear of aversive consequences patients, because they're worried about that food triggering that feared outcome in them. Reliance on nutritional supplements is very common between our selective eaters and our fear of aversive consequences patients. So if you have a patient with a choking fear who's not eating solid foods, but they're drinking a ton of Ensures each day, or our selective eater who, because a parent is worried, rightly so, about a nutritional deficiency, has them eat a supplement, because then they can at least ensure that they're getting their fats, their proteins, their carbohydrates, and all of the vitamins and minerals that they need. And as I said, while these presentations can overlap, there are some things that we've started to learn are kind of specific to each one of these presentations. So a recent study that was published by a group of Canadian researchers found that patients, for example, with sensory sensitivity were actually much more likely to be cis males. So the gender disparities do shift depending on the presentation. Our patients with sensory sensitivity are also more likely to be at a healthy weight for, again, their age or their development or their body type. They also are the ones most likely to have strong gagging responses and be very specific, restricted in the overall number of foods that they will tolerate and eat. Someone who has fear of aversive consequences is much more at risk for experiencing weight loss and needing hospitalization. So this group of patients makes up by far the vast majority of ARFID patients that wind up in the hospital on like a medical stabilization unit. They also tend to have a much shorter duration of illness, a much more acute onset. These are patients who are most likely to have been very typical eaters and growing quite well until a traumatic event happens or until this fear develops. And then our patients with lack of interest are most likely to have sort of a lower kind of total overall percent median BMI that has been pretty long standing. So these are the patients that over time just have always sort of ridden at those lower growth curves. Interestingly enough, we also find higher rates of ADHD in this group of patients, which I have lots of theories about. So if anybody wants to ask me questions about ADHD, I love talking about the overlap of ADHD and ARFID patients. So we can get to that in the question and answer session if you want. Fear aversive consequences, though, and lack of interest, both of these groups tend to be the groups that need weight restoration, that also tend to have a lot of the somatic symptoms, and also just overall don't eat enough foods. So while they can co-occur and overlap, there are some features that are pretty specific or distinct to a specific presentation. Now, why it's important, I think, for us to keep in mind the fact that these are overlapping presentations is because it's really helpful for us to think about what causes them. And if we think about what causes each of these presentations, it makes sense that it's not reasonable for a patient to struggle in just one area and not others. So for example, if I break my arm, it doesn't mean that I can't also break my leg. It's not like just because I have a broken arm bone that I like for some reason can't have a broken leg bone. So if we think about if the way we think about ARFID is that underlying each of these presentations is some specific kind of deficit or dysfunction, it makes sense that a patient could then develop dysfunctions or struggles in multiple one of those areas. So just because I'm sensory sensitive and I may have some sort of abnormality in the perceptual areas of my brain. So I have trouble in the way that my brain processes or perceives foods, or the threshold by which I pick up on sensory differences. It doesn't mean that I can also be somebody who is more programmed to see the world in a threatening or anxious light. So we know, for example, that people in general who are more at risk for anxiety disorders have sort of like a higher threat detection in their brain. So they're more likely to see errors in their environment or to see threat in their environment, and they're much less able to tolerate that. Or they have a brain that's just more prone to overgeneralizing their fear learning. So this is the person who they encounter a dog who barks at them and is really aggressive. And then instead of walking away from that interaction and thinking, oh, that dog is really aggressive and scary, they walk out of that interaction and think all dogs are aggressive and scary. And we know that those people are much more likely to develop issues with anxiety. And so somebody who ends up developing fear of aversive consequences might have a brain like that, that's much more readily identifying threat and much more likely to overgeneralize their fears. And then same thing with our lack of interest patients, that probably one of the things that's underlying that lack of interest is maybe some sort of disruption in the way their body regulates appetite. And the really kind of, I'm going to use the word fun because this is like my nerdy brain thinks this is so interesting. One of the really fun things that's coming out of the research right now is that, yes, indeed, we are identifying abnormalities in the hormone function in these patients who have poor appetite. And that's different from patients with anorexia, and it's different from our healthy control patients. So again, encourage you, don't think about these things as being separate things, particularly because if you choose to focus only on one of these presentations, you may miss out on some really important factors that you'll need to take account into treatment or that might influence the course of your treatment. So remember, these are more areas of dysfunction, or I like to say sort of presentations. They are not mutually exclusive categories. Okay. I think I skipped over something a little ways back in here that I think we can probably leave be, but more just sort of talking about the fact that, again, ARFID is a lifespan diagnosis. I think a couple of other things to just sort of mention is that in addition to, again, making sure we recognize ARFID is happening in both children, adolescents, and adult, I think one of the points I wanted to make earlier as well is that ARFID also can co-occur in the context of other like medical conditions or medical comorbidities. So if you have questions later on about whether or not, for example, someone like with Crohn's can have ARFID or some other documented disease, we can talk about that as well and how you might distinguish those two. So moving into more of the assessment phase, and I do think the assessment phase in ARFID is such an important phase. I really emphasize to my patients and my families like how important it is for me to understand their ARFID, because it has such big implications for the way that I treat it, not just in the treatments that I do for them, but also in terms of bringing in complementary treatments to work with this patient or with this family. So starting point, if you're the kind of person who loves a good diagnostic assessment, here are three that I'll recommend to you. The NIAS, or the 9-item ARFID screen, is probably right now the most popular screening assessment for ARFID. It's short, just 9 items, and it has clinical cutoffs. So a really easy way to kind of do just like a quick and dirty, like, does this patient have ARFID or not? It's also able to be used in children as young as 8 years old, and it's been translated into 2 different languages in addition to English. So it's a really nice kind of accessible measure to use. The second assessment is an interview, a semi-structured interview, so called the PARTY, which is the best name for an assessment ever. PARTY stands for Pica and ARFID Rumination Disorder Interview. The nice thing about the party is that it is diagnostic. So you can walk out of this interview feeling very confident that your patient meets the DSM diagnostic criteria for ARFID. The other advantage to the party is that you can use it in a really wide range of ages. You can use it in kids as young as 2 because it has like a parent-only version with questions that are sensitive to that younger age range. But you can also have a you can have kind of a self-report version that you can use with adults. It's been translated into French and Dutch. A lot of research going on in Europe with the party. And it also has that exclusion criteria. So in addition to screening out for pica and rumination disorder, it also includes criteria to screen out for eating disorders where there's a body image component. The party as well now comes in a questionnaire version, which is great for those of us who don't have the time to do a lengthy diagnostic interview in our practice. So the party ARQ, it is available online from a group in London. I'll have to double check exactly which hospital has this, but the party is publicly available online, the questionnaire version. Again, this is one that does a great diagnostic screen. It also gives you an index of severity. So if you're somebody who likes to track outcomes over time, the severity index is a great indicator of, again, like how impairing are my patient's ARFID symptoms, and can use it again in a wide variety of ages. There's a parent report version for kids as young as 4 and a self-report version that starts at 14. All right. A couple of other measures that I think are handy to have like in your arsenal when you're working with ARFID patients, particularly if you really like measurement-based care. The food neophobia scale is one that I really recommend, particularly for tracking how well your more selective eaters are responding to treatment. One of kind of the tricky things about assessing selective eating is that there are a lot of people who their selective eating kind of becomes a part of their identity. And so you might have a patient who identifies as picky and who is a very selective eater. And over the course of your treatment, you end up adding 16, 20, 25 different foods. But because a lot of those foods might be in the same food group, or they might all look really similar to each other, this is somebody who maybe functionally has really improved their eating, but still is pretty picky and identifies as being picky. So the trouble with using some measures like the NIAS, for example, to track outcomes is that it does seem to be somewhat identity-based, and it's not really a great index of change. So the food neophobia scale is a great one because what it measures is fear of new foods, of trying new foods. So for example, I don't trust new foods, or I will eat almost anything, reverse scored. This is a great one because it sort of measures a patient's willingness to try things. And what we find is that when patients are more willing to try things and they're less food neophobic, this is a pretty positive indicator of response to treatment and in terms of overall functionality. So food neophobia is a great thing to track, particularly if you're working with a patient who is really selective. I do note, though, that there are 4 items on this 10-item scale that have a bit of cultural bias in them. And so I tend to leave them out when I administer this measure. And I know other people in the ARFID field also tend to leave this measure out, or like these 4 items out. So I just want to note that here. And then finally, I also really like food frequency assessments as part of my assessment process for ARFID. The reason why I really like food frequency assessments, and these are assessments that often are used by dietitians. They measure how often a person consumes different types of foods. They're usually pretty broad strokes and easy to fill out. So for example, I eat bread never, less than once a week, 1 to 3 times a week, every day. And why I like these is because it's a really great index of that nutritional risk piece, but also the degree of the selectivity. So I use this for helping me with my assessment, but also with my treatment planning, because it gives me usually these measures give me a really quick kind of peek into which categories of food my patient is eating from and what is their variety like within those categories. So for example, if I have a patient who says they're really picky, and this happens a lot. I have a parent bringing their kid and their parent is like, they're just such a picky eater. It's a huge problem. But then I have them fill out a food frequency assessment. And what I find is that this is a patient who's eating from ARFID food groups. And actually, they have at least like 3 or 4 food items from like all of those food groups. And we know that if you can eat at least 3 to 4 foods from all major food groups, you are at significantly reduced risk of developing a nutritional deficiency. So that's a patient where I'm like, they're actually doing pretty good. Whereas if I have someone fill out a food frequency assessment and I see that they don't eat any fruits or vegetables, I know that right away that's the place where I might need to focus a lot of my work with that patient because they're missing 2 whole food groups from their diet. For those of you who are familiar with family-based treatment for ARFID, there's a tool in there called the Always, Sometimes, Never list. It's pretty much the same thing as a food frequency assessment, except when a patient fills it out, they're doing it kind of from recall and they're not going through a list of foods. So the goal of this assessment is a patient list. These are the foods I always eat. No questions asked. They're easy for me. These are the foods I sometimes eat. So it might depend on my mood, or it just might depend on like what the presentation is or how they were prepared. So they might be sometimes hard for me to eat, but sometimes I can push myself to eat them. And then the never foods. These are the foods I never eat, but that I'd like to be able to eat, or it would be really nice if I could eat them. And that can also give you a really quick way to assess how at risk my patient is based on variety. There are a couple of other options for doing these assessments. Sometimes a food recall can be another way to get at, again, overall variety and how at risk someone is from a variety perspective. And we're going to talk about cognitive behavioral therapy for ARFID in just a second, but there's a great sort of food frequency assessment in that manual as well that you can use. Some of these food frequency assessments are like pay only, so it's hard to access them. Another thing I like to talk about, and that I get asked about a lot when I talk about assessment, is, well, how do you tell if it's ARFID or anorexia? And I feel like at every talk I go to more and more these days, I'm getting asked as well about adults, particularly adults, sometimes teens though, with more quote unquote traditional eating disorders like anorexia, wanting to present as though they have ARFID, or trying to say that they have ARFID instead of anorexia as likely maybe a way to influence the kind of treatment that they'll get. This is a great question. And I will totally say that, regardless of the motivation, I do think there are lots of cases in which it can be really tricky to tell whether or not this is ARFID or whether or not this is anorexia in particular. I think it's much more easy to distinguish ARFID from like bulimia nervosa or binge eating disorder. Another question I also get a lot is, can you have both? Can you have ARFID and another eating disorder co-occurring? That is a question that is still very much up for debate in the field. I will say that me personally, I lean a little bit towards yes. Can they both be active at the same time? That I'm unsure about, but I have definitely had patients where I've had patients with anorexia where I have very much needed to recognize also an ARFID diagnosis in order to be able to effectively treat the anorexia. So keep an open mind here. The way the DSM is written is that you can't have both. So if you have ARFID and you have body image disturbance, and that is also influencing the way that you eat, you can't diagnose the ARFID. You have to diagnose the anorexia. And I will say probably most often, if you think your patient has both, it's often pretty clear which one is maybe more impairing. And so often you might have symptoms of both, but like you need to attend to the anorexia first before you can attend to the ARFID. So we've got a little bit of research that has started to help us maybe sort of piece apart these two disorders a little better. I will say, I think that this differential diagnosis is more complicated or harder if you have a patient who presents with what I'd say is more colloquially known as non-fat phobic anorexia. So these are patients with anorexia that don't have an overt, that are not proclaiming to have like an overt fear of fatness. And they may even say like, they may even deny fear of gaining weight. That's, I think, when this differentiation becomes a little bit trickier. But there's a little bit of research that's beginning to help us with figuring this out. So the first is some research now that there are some attitude biases that help us differentiate ARFID and anorexia. So in one particular study using the implicit attitudes test, they found that someone with anorexia is more likely to have definitely a bias towards like having positive associations with thinness or with dieting. So kind of, asking your patient again, even though they have ARFID, well, tell me about like, tell me how you feel about your body. Tell me how you feel about, for example, what's your philosophy on like healthy eating or things that try to get at like some of those diet culture biases. And that might be one way to begin to sort of say like, oh, okay, so this patient has a lot of maybe strong wellness beliefs about food, or who still has some kind of thoughts about like equating thinness with being healthy. That might be a way to differentiate. Also, the characteristics of restriction. There are some things, and this is based on just a few studies, so I caution you around this, but this is based on a study of only six patients who were initially diagnosed with ARFID, whose diagnoses were later on changed to anorexia. And some of the things that they had in common at the start of treatment were more worries generally related to health. So these patients presented as more like fear of aversive outcomes, but their worries were around like becoming unhealthy, or developing different like kind of health related, I shouldn't say health related disorders, because like all disorders are health related, but like I would say like nutrition related conditions. So like diabetes, or like maybe they had beliefs about like their overall health and like likelihood of contracting cancer or developing cancer. And then also higher rates of vegetarianism in patients who are originally diagnosed as ARFID and later changed to AN. So I would also kind of be cautious around patients with ARFID who maybe adhere to a specific kind of diet. Timeline is also important. While not true for all ARFID patients, a lot of ARFID patients tend to have a much more kind of lifetime onset of their disorder onset very early in life, or at least you can detect significant struggles with eating dating back to like birth and toddlerhood. So many of my ARFID patients were described as really difficult to feed when they were infants. They had trouble with breastfeeding or with latching, or they struggled to transition from bottle feeds to solid feeds. But also another way, so anorexia is much more likely to develop acutely after a period of normal eating. Our fear of aversive consequences patients are similar to that too. So remember, it doesn't entirely rule out ARFID, but timeline can also be. If you have a patient who was a very typical eater at one point and now isn't, my antennae would be up to think anorexia. But also sort of watching how things develop. So maybe it's not clear at the start of treatment if it's ARFID or if it's anorexia, but all of the patients in that one study of 6 patients who initially were diagnosed with ARFID and their diagnosis was later changed to anorexia, all of them developed weight and shape concerns during the weight restoration process. So they were all lower weight to begin with. They all needed to weight restore, and those weight and shape concerns emerged as weight restoration progressed. And then finally, there are a couple of behaviors that if they're present, I would be super unlikely to diagnose ARFID. So we just don't see high rates of binge eating, either subjective or objective, in our ARFID patients. We also just don't see compensatory exercise. That doesn't mean that our ARFID patients don't exercise, but they're not doing it to make up for the calories that they ate, or the fact that they had a hamburger or ate fast food or something like that. And we don't see voluntary purging. I have many ARFID patients that I've worked with who threw up very frequently, but it was more involuntary. It was due to volume intolerance, or they got so worked up into a panic that they vomited, or they had really sensitive gag reflexes, and they were so distressed by their vomiting. So if it's voluntary purging, then I would also be very apt to rule out ARFID and more diagnose bulimia nervosa or anorexia binge purge type. Okay, a couple of other things I want to touch on in the assessment phase, mostly because this is where I think care for a patient with ARFID really starts to depart from the way we care for something like anorexia or nervosa. And that is, in our ARFID patients, it is really important that we account for or rule out any other kind of condition that could be making eating harder or more painful for this person. So unlike anorexia nervosa, where I'm more apt to not attend to other physical complaints or symptoms or diagnoses because I find that they're often a distraction from the anorexia or interfere with our ability to treat the anorexia. In ARFID, I find that actually attending to these things and making sure they're properly cared for enhances my treatment and makes it more effective. So I really encourage you all again to sort of, at the start of working with an ARFID patient, like just put on your brainstorming hat and think, okay, is there anything that could be going on here that might be contributing to this? And I'm not trying to suggest that we're looking for some other medical diagnosis to explain the ARFID. Like if we just treat this medical diagnosis, magically ARFID will be taken care of. But it can make the ARFID treatment so much easier. So, and I will say that some of these things are things that probably already got ruled out in childhood for a person. But I have had many patients where, we discovered, for example, that they had celiac disease when they were 12. And well, that's why it was so hard for them to eat for so long. Or where we ended up screening them for something like eosinophilic esophagitis and discovered that they had it. And even though that might explain sort of why they struggled to eat, because their diagnosis went so long undetected, now all the secondary anxiety around eating has developed. And now again, we have ARFID in addition to the EOE. So 3 specialties in particular that I often recommend patients talk to, depending on various red flags, and if they haven't had these evaluations in their history, are gastroenterology, speech-language pathology or occupational therapy, and then allergy or rheumatology. So for gastroenterology, we're screening for often more disorders of gut-brain interaction, but sometimes actual gastrointestinal diseases like irritable bowel disease, or celiacs or Crohn's. But other really common ones to kind of want to sort of account for or screen for are these disorders of gut-brain interaction or DGBIs. These are your irritable bowel syndrome or functional dyspepsia, cyclical vomiting, for example, or chronic diarrhea or functional constipation. And SIBO, which is a bacterial infection of the gut that often impacts, that causes a lot of pain and impacts volume tolerance and general gut function. With OT, we're looking for whether or not there's the presence of an oral motor skills deficit, which again, if you're dealing with an older elementary school aged kid and up, unlikely that this is present. These are usually things that are more applicable to that 0 to 5 window of development. So if you're seeing somebody older for the first time, highly unlikely they have an oral motor skills deficit, but it's happened to me before. So just kind of think about that if they've never seen OT or SLP for their feeding issues. That might be a referral you want to consider. We're also looking for, though, things like sensory processing disorder here. And while, again, sensory processing disorder probably doesn't fully explain their ARFID, it may have been a really important contributing factor. And it'd be great to give the patient or the family skills for managing their sensory needs alongside treating their ARFID. And then finally, with allergy and rheumatology, we're looking for, these are my red flags. Sorry, these are not the actual disorders that we're looking for, but we're looking for possibly undetected allergies. Even in my ARFID patients, I'm kind of looking for also maybe sensitivities. So I'm much more apt to accommodate sensitivities or take that into account, simply just because if I can make eating any less painful or any less uncomfortable for my ARFID patient, my treatment is probably going to go more smoothly. So I switched these things here. So I'm looking for food allergies or food intolerances. These are my red flags. So in general, like I said, look at the history, see if they've ever been to see any of these specialties. If they haven't, consider a referral, but particularly if they have these red flags. So for gastro, I'm looking for frequent abdominal complaints, abdominal pain, vomiting, constipation, diarrhea, effortful swallowing, which is a hallmark of EOE. So either food actually getting stuck in the esophagus or just it takes them like often drinking water. It's like if you ask a patient, like if I gave you something to eat and I didn't give you any water to drink, could you eat it? EOE patients can't. They have to have some sort of liquid to help with washing it down. For OT, I'm looking for general aversion to sensory input, any type of like weird like eating behaviors like messy chewing, tracking food along the gum line, taking kind of like multiple attempts to swallow things, avoiding using utensils. So if you're working with younger kids, it's a good possible referral to OT. And then for allergy and rheumatology, I'm looking at also for things like abdominal complaints. If you're noticing patterns of complaints in response to eating specific foods, if there's a history of eczema in the patient or in the family, and if there's a family history of food allergies, also something to screen for as well. Okay, so let's get to treatments. I want to go over sort of 4 categories of treatments for ARFID. I want to talk somewhat a little bit about behavioral treatments, although these mostly apply to very young kids. I'm going to talk about family-based treatment for ARFID as well as cognitive behavioral treatment for ARFID, and then talk a little bit about various like medications or medical approaches. Now, I'll say this last category, the medications and medical approaches, these are not standalone treatments for ARFID. So these would always need to be complementary to doing something else, either a behavioral treatment, a family-based treatment, or a CBT treatment. So I want to start with behavioral treatments and get these out of the way because, again, these mostly apply to very young kids. But you know, when we in eating disorders discovered ARFID, we didn't actually discover ARFID. ARFID had been around for a really long time, but it lived in the world of feeding disorders. And if you've historically always worked in eating disorders, you probably don't know much about feeding disorders because it is a very different group of kids than what you might work with and see in eating disorders. But the feeding disorder field had been around for a really long time, and they were already working with these patients. And so there were a lot of things that they had already figured out when working with these patients. The feeding disorder world's bread and butter really is in the patients who have the sensory sensitivities and who are selective eaters, as well as some patients who have just sort of general aversion to like food and meal time. So a lot of these treatments were implemented really for infants, for toddlers. So these were often kids who had some sort of like medical complication at birth or early on in life, where they then experienced maybe secondary medical trauma as a result of like extended feeding on like an NG tube. And so a lot of these treatments are just really specific. So if you think about something like ABA therapy, when done well and done correctly, is really effective at treating ARFID in these younger kids. But these are also treatment approaches that have not really been systematically evaluated in older school-age children and beyond. So very reluctant to apply a lot of these principles to an older child or to teens or adults. They're really specific to young kids. And typically these are delivered in more of a traditional feeding setting, so a feeding disorder clinic or a feeding disorder program. They're very multidisciplinary. They involve speech and language pathology, OT, psychology, nutrition, as well as GI is usually the MD affiliated with these clinics or programs. So we're not going to talk a lot about these today, simply because I really recommend if you have an ARFID patient who comes to you who's 6 or younger, particularly if it's sensory related or kind of lack of interest, feeding clinics are usually my first stop for those patients and my first recommendation. Now, going into the medical treatments, which I said, remember, are complementary. These should not be standalone interventions. There are now a couple of medications that have limited amounts of study in ARFID. We need a lot more research on meds in ARFID, but there are a couple of things that have started to emerge as more kind of routine considerations. So there are a couple of non-psychiatric meds that you'll often see ARFID patients on. So those include things like ciprofloxacin or Periactin. These are appetite stimulants that have more of a kind of a histamine mechanism of action to them. They tend to be meds that get cycled. So they're really well tolerated. They do have some limited efficacy. I've often found that by the time ARFID patients reached me, they weren't getting a lot of help from from these meds. And as I said, they have to be cycled. So they only work for a short period of time, and then the patient has to go on a break from them and then restart them. So I don't love that in terms of like a long-term like care or routine or consistency plan. Zofran, which is an anti-nausea med, Megace. There are adult patients that I've seen that have been put on Megace. It is a very heavy duty appetite stimulant. We typically usually see it used like in the context of like chemotherapy and cancer treatments. Not a good thing for your patient to be on Megace. If we can get them off of Megace, that would be great. But in extreme cases, I've seen adults be put on Megace. Psychiatric medications, probably one of the front runners right now, and where a lot of attention is being paid, is to a medication called mirtazapine or Remeron. It is an SNRI, so a serotonin norepinephrine reuptake inhibitor, commonly used depression antidepressant medication. And why we have started to use Remeron with ARFID is because there's actually some literature on bringing on board Remeron in patients, again, who were actually undergoing cancer treatment and who struggled with appetite and nausea. And Remeron has, for some reason, a really great impact on something called visceral hypersensitivity. So that is like sort of this excess tension in the muscle walls that can be very painful. And Remeron seems to do a kind of nice job of relieving that. So you get some nice sort of anxiolytic properties from Remeron as well because of the serotonin action and the norepinephrine action, but it also seems to help with some of those like somatic symptoms. So mirtazapine is often usually the first med that I recommend my ARFID patients look into if we think we need to add a medication, like if we're not making progress or if they're interested in it. Zyprexa, so we know Zyprexa from its work in anorexia, really helps us with weight restoration in patients with anorexia. We've looked at it for the same reason in ARFID. So I would say anecdotally, where I've liked to see Zyprexa used is with my ARFID patients who are underweight, who have fear of aversive consequences. Because you get kind of a nice anxiolytic effect from Zyprexa, but you also get the weight restoration help from it as well. And those are the patients who are most usually struggling with weight. There's a case series looking at SSRIs being used in conjunction with Zyprexa. There's also like one very small randomized controlled trial of using a med called D-cycloserine, which we learned of from the OCD field, and found that D-cycloserine, when provided about 30 minutes before doing a food exposure, helped with food exposure learning. So these patients were able to add more foods or increase the number of bites of new foods that they were able to take. So again, these are just considered to be adjunctive. These are not frontline treatments and they are not standalone treatments. But if you have a patient with ARFID that's a complex case or that's not making progress, highly recommend you looking into maybe some of these medication options. As I said too, I'm a big fan actually of these complementary treatments. And so if I have an ARFID patient who has a disorder of gut-brain interaction or who has a lot of GI symptoms, all of these are evidence-based treatments for these more functional somatic GI symptoms. So again, a GI referral to see what a GI clinic could offer in terms of relieving pain or helping with motility in our ARFID patients. I have found these to be helpful. I had an ARFID patient who he would kind of like cycle through these waves of being able to, he had poor volume tolerance. So it was really hard for him to increase the amount of food he could eat, and he really needed to gain weight. And he would like cycle through these periods where it would be just like a lot harder for him to eat and his intake would drop off. And we eventually connected it with constipation. And once we brought like Miralax online really regularly and got him on a good regimen, it made a huge difference for his appetite. So things like laxatives or stool softeners, prebiotics and probiotics, diet modifications, although you have to be careful with this one. Sometimes dietary modifications can actually increase risk for ARFID. So just be very careful around making sure that like, if you're going to recommend diet modifications, you know exactly why you're doing it. And like definitely making sure your patient is in the context of care with you or getting therapy while you do this so that we can make sure it doesn't kind of spiral. Acupuncture and acupressure are great for GI pain. Some nerve stimulators, actually tricyclic antidepressants, are great for functional abdominal pain, although they have a lot of like scary side effects sometimes. Various botanical supplements like peppermint and ginger and chamomile tea helps with some like GI complaints as well, and actually hypnosis. I don't recommend hypnosis as a standalone treatment for ARFID, but there is evidence to support hypnosis in relieving abdominal pain. So moving on now to kind of what I feel like at the moment are probably the front runners for standalone psychotherapies for ARFID. These are cognitive behavioral therapy for ARFID, or CBT-AR. This is an intervention developed by Jenny Thomas and Cameron Eddy, who I think just are really kind of leading the field in terms of understanding ARFID. They've got an R01 big NIH grant that's looking at that's looking into a lot of those biological contributors to ARFID. I just really like the work that they're doing. And then family-based treatment for ARFID. So an adaptation of FBT, which we know is a great treatment for children and teens with anorexia nervosa. This has also been adapted to meet the needs of ARFID patients. So there's a lot of similarities between these two treatments. They happen in phases. Both treatments have the philosophy of always prioritizing weight restoration before doing anything else if it's needed. So that's very classic of FBT. CBT-AR emphasizes it as well. So that stage 1 is really focused on like jump-starting weight restoration if a patient needs to do it. But they diverge after that. So ARFID has CBT-AR has a much more kind of intentional focus on those underlying or maintaining drivers or mechanisms of ARFID, with very specific treatments for depending on if your patient has sensory sensitivity, fear of aversive consequences, or lack of interest, all based on other evidence-based treatments from other fields or related fields. Whereas FBT follows much more the lead of the family, and again, doesn't adhere to any specific kinds of intervention, but really approaches it from a much more collaborative standpoint with the family to kind of problem solve how to address the specific eating problems that a patient presents with. I will say that there are some important like age differences to keep in mind. Both of these treatments have pretty good data to support their initial efficacy. CBT-AR, though, is the only one that's been tested in patients older than in 10 and up. So CBT-AR is really going to be your go-to if you're working with a teen or an adult. If you are working with a really young child, probably FBT-ARFID is going to be a better starting point. FBT-ARFID has been tested in ages 6 to 12. CBT has a lower limit of 10, so it's not recommended right now for children younger than 10. I will say that one of the things that I do like a lot about CBT, and that is really core to its effectiveness, is exposure. You'll see 3 kinds of exposure therapies used within CBT-AR. So food exposure for dietary expansion is used for our sensory sensitivity patients. This uses or relies on a technique called systematic desensitization. They also are incorporating a very popular approach from the OT field called sequential oral sensory approaches to trying new foods. And then both cue-based exposures and interoceptive exposures are used to target more of the fear presentations of ARFID, as well as actually the lack of interest presentation to help with volume intolerance. I love interoceptive exposure for helping my patients with volume intolerance. The manual for CBT-AR has very detailed approaches on how to implement these 3 types of exposures, as well as indications of when to do them. I'm going to show you some data, but we're also like 2 minutes from our time up. This is the data from the randomized controlled trial of FBT for ARFID. The only thing that I really kind of want to point out on here, and I don't know if I can use like a laser pointer or something. Yes, I can. Okay, so the thing that I want to really point out here, so these are our patients who were put into the FBT ARFID arm at baseline, usual care. Not a ton of differences between these 2 patients at baseline. Here is end of treatment, so you can compare where ARFID patients were at compared to the usual care patients. Again, sometimes not a lot of differences between the 2 in terms of like overall weight gained, but if we look at the differences, the deltas, Our ARFID patients actually gained slightly more weight over the course of treatment than our usual care patients. Pretty big differences also, though, in drop in severity scores. So our patients with ARFID experienced a clinically significant drop in their severity scores compared to the patients in usual care. One of the things I like to talk about, though, in this study is that none of the patients in the FBT ARFID study no longer met criteria for ARFID at the end of the study. So meaning they improved, but their ARFID wasn't fully resolved at the end of FBT treatment. Now, compare that to CBT-AR. So CBT-AR has now had a pilot study in both children and adolescents as well as adult age groups. The data are pretty equivalent between the CBT-AR and the FBT group in terms of like overall severity score improvement. But there are some, I think, really important differences here. So in CBT-AR for children and adolescents, we saw that about 85% of the patients were rated as much improved or very improved by their caregivers. We also had only 41% of patients at end of treatment still met criteria for ARFID. So about 60% of patients no longer met ARFID criteria at the end of treatment. Probably the biggest difference between FBT for ARFID and CBT-AR is that, at least according to parents, there was a significant portion of their kids who no longer met ARFID criteria at the end. So that speaks to not only an overall improvement in health, but also an overall improvement in functioning. And on average, patients in CBT-AR added 16 new foods over the course of the treatment. In adults, similarly, this is again the only systematic outcome data we have in adults. These were adults who had been sick for a very long time, an average illness duration of 17 years when they presented to treatment in this trial. They added, on average, 18 new foods, had very large effect sizes for reducing the overall severity of their ARFID, improving their sensory sensitivity, and improving their food neophobia. And at the end of treatment, almost half of patients no longer met criteria for ARFID. So these are pretty great outcomes. All right, we can move on now to the question and answer portion of our session. So I'm going to go ahead and stop sharing my screen. And
thank you. We have quite a few questions come in, and please feel free to add any more if you have any questions. Thank you for an amazing presentation. That was awesome. First question, do you have any suggestions on how to increase interoceptive awareness around hunger and fullness with those who might struggle with connection to their bodies, particularly with neurodivergent clients?
Yeah, so I think that for patients who are neurodivergent, I think often I find you've got to get a little bit more concrete. So, for example, I would maybe even recommend looking into, there's a great treatment that's being developed at Duke University by Nancy Zucker called, and it's developed for really young kids, but there are things I like about it for the neurodivergent group, but it's called the Feelings and Body Investigators treatment. And there's like a specific one for ARFID patients. And a lot of it is about just sort of teaching patients about their bodies in very concrete terms, because it's developed for really young kids. So I think kind of like using sometimes, I think, really well articulated hunger and fullness scales where you're giving them very concrete, specific things to look for, like, feeling certain things in your tummy, or feeling, your heart flutter, or you're just looking for those super specific cues. And over time, kind of just teaching them to track them and tune into them. Just even the practice of having them try to estimate their hunger and fullness levels, again, maybe in more concrete terms. So maybe like a number scale doesn't work super well for them, but you could ask them, okay, do you feel like you could eat more food, or do you feel like you can't eat any more food? Are you feeling angry and irritable right now? So teaching them those cues to look for, and then having them just practice sort of estimate or best guess pre and post meal might be a great way to start.
Thank you. In young children 4 to 6 years old, how do you differentiate picky eating and ARFID? Can a therapist alone diagnose this?
absolutely a therapist alone can diagnose this. So as I mentioned, that differentiation is going to be are there any sort of secondary impacts as a result of the picky eating? So if you have a picky eater who is socializing just fine, they can go to other people's houses, they can eat at other people's houses. I mean, even if all they do is go to that other person's house and eat like Cheetos, for example, or eat pizza or something like that. They haven't lost weight. They're growing just fine. They don't require supplements to kind of keep them on track nutritionally. That patient doesn't have ARFID, right? Like there are plenty of kids who are picky eaters who do not meet criteria for ARFID. So you're really looking for that impairment piece. And does the eating, the way the kid eats or the way the kid prefers to eat, does that cause problems? Have they stopped growing, or are they having trouble growing, or have they lost weight? Is it an ordeal for them to eat outside of the home? So can the family go on vacation? Can they go to eat at a restaurant? Like how hard is it for them to eat in other settings outside of the home? And then again, is this causing problems with like relationships, whether or not they don't want to eat in front of other kids at school? And again, they are nervous to go to other social events because of their style of eating, or because they're afraid they won't be able to find something to eat. Then we're dealing with ARFID, and look at sort of the way the family accommodates it. So what lengths does the family have to go to accommodate it? So if you've got a picky eater and you have a family who's just figured out how to run with it and it's pretty low level, like for example, with my kids, I would totally describe my kids as being pretty good eater, but they're picky about some things. And so like, I just know that if like I'm really craving like a certain meal that they won't eat, I've got an easy swap in that I do for them, but I don't have to do it every night. I don't have to prepare my kids a separate meal every single night. And I also can serve them their preferred foods within reason, like slight variation. Like maybe I overcooked the pasta one night, or maybe like I didn't melt the butter exactly into the toast the way my 4-year-old prefers, but he can eat it, right? I don't have to go to great lengths to accommodate their pickiness. And it's something that doesn't cause me a lot of extra burden as a parent. So that's another sort of marker as to whether or not that picky eating is ARFID, or whether it's just like, all right, it's picky eating.
Thank you. I have a client who initially started presenting as anorexia nervosa, but now is showing more concerns related to ARFID. I'm an FBT therapist, and the parent wants to not push client to work on ARFID treatment and wants to only pursue anorexia nervosa treatment at this time. What would you recommend in this situation?
Oh, I have so many follow-up questions for you because I want to know what the ARFID concerns are. I think that like impacts what my answer is going to be, but I'll try to answer it generally, which would be that I would be a little bit hesitant to say like, let's only pursue our anorexia treatment and sort of ignore the ARFID, because there are ways that we might treat anorexia that could actually make the ARFID worse. So, and it's hard for me to kind of like go into great detail about that here, but essentially like, there might be advantages to trying, maybe it's not that we switch treatments, but is there a way that we could maybe take the patient's ARFID treatment more into account? Like I would just be really concerned about like, for example, there's some strategies that I might use with anorexia that I don't use with ARFID. Like with anorexia, I'm a big fan of being pretty rigid around the meals, around the rules around meals. Like I tell parents when I do FBT, and I'm like, the key to treating anorexia is you got to close all the exits, right? Like you have no choice but to eat. And with ARFID, I'm a little bit more flexible. If I try to be like super rigid and absolutist in my rules with ARFID, I'm actually going to probably causing like some harm and maybe even making things worse with my ARFID patients. It's just not going to be as effective. So I think it really depends in part on like what the patient is struggling with ARFID wise. So sometimes if it's more selective eating, then it's just adjusting what I'm having my parents serve their kid in the course of anorexia treatment. Like if my kid is sensory sensitive and they are really selective, well, I can refeed a kid on their preferred foods. Like I can stay within their preferred foods from like a sensory and a taste perspective and weight restore them and treat their anorexia. If it's like a fear of aversive consequences, that one becomes a little bit trickier. And again, I think that's maybe beyond like the scope of this presentation and Q&A session, but I would really give a lot of thought to how the ARFID is impacting the anorexia treatment. And I think if there's any sort of interaction there at all, I think you're going to need to take it into account. And like I said, I don't think it's maybe switching, but it might be seeing like, is there anything we can add? Or are there things about the way we're addressing the anorexia that we could maybe be more flexible on without compromising the weight progress that we're trying to make? So we can maybe do like a whole presentation maybe on treating ARFID and anorexia together.
Thank you. Not so much a question, but just some people in the chat wanted to hear more about the connection between ARFID and ADHD.
Yeah. So so this is something in my own clinic and my own experience I've also found. So in my pediatric clinic, about 35% of our patients with ARFID also had comorbid ADHD. So a really significant overlap. And right, the tricky thing with ARFID and ADHD, right, is that our most common treatments for ADHD are stimulants. They work really well for treating ARFID, but they can have very significant appetite suppressing side effects. So I've had a handful of cases where it was probably ARFID induced by stimulant medication. And once we discontinued the stimulant medication, the appetite issues resolved and the patient was able to gain weight. But what I more often find is that that's not a helpful approach for when I work with my ARFID and ADHD patients. So the really cool thing I think about ADHD is that I think our understanding of the neurobiology is more that ADHD is driven in large part by some abnormalities in our motivation and reward processing systems. So often, you can think about ADHD as being more of a disorder of motivation. So patients with ADHD struggle with engaging in goal-directed behavior, but particularly when goal-directed behavior is not inherently motivating or reinforcing. So that's why you can have someone with ADHD who can just play their video games for 6 hours a day and focus really well in that context, but they really struggle in the classroom because let's face it, writing essays and doing math problems is not something that we find super exciting and inherently motivating. So that's where ADHD patients struggle, or patients with ADHD struggle, is it's when that task is not reinforcing, that's when they struggle. They can't persist with that task. And if you have someone with ARFID, what is a task that is really not motivating and not reinforcing? Eating, right? So eating is either painful or it's difficult, or you don't like to eat a lot of things. And for most of us, we can push ourselves to eat, for example, when we're not hungry, because in general, we enjoy food. But for someone with ARFID, that is eating is a goal-directed task. And if they have ADHD, that is really probably going to worsen or negatively impact their engagement in that task. So I really am of the recommendation that these are two things that have to be treated at the same time. And I have successfully treated many ARFID patients while keeping them on their stimulants, and actually found that I could only successfully treat their ARFID if I kept them on their stimulants, because they needed that help to engage in the eating task. Now, I would say in almost all those patients, we had to add a secondary medication to help counteract the appetite suppressing effects of the stimulant medication. But my philosophy with ARFID and ADHD is you got to take both into account, because the ADHD is going to make it harder for you to treat the ARFID.
Thank you. Let's see. How do you navigate a teen client with minimal safe foods, no nutritional variety, with no interest in addressing ARFID? Mom is concerned, but client is in pre-contemplation.
Yeah. Oh, that's such a tough one. So I think that with most people, we can't force them into treatment. We can't force them into getting better. I think probably my first line would be seeing if I could work with parents to set up some sort of motivational system. We have to do it in a lot of other treatments, like psychotherapies for teens. For example, one of actually the most evidence supported interventions for teens with depression is using rewards. So it might be that we've got to work with that parent to set up some sort of motivational system to, I don't want to use the word force because that sounds terrible, but to enhance that patient's motivation or willingness to engage in the treatment process. I'm not usually concerned about buy-in, because all of our data on behavior change suggests that usually the behavior changes come first before the buy-in comes. And so if I can even just get the patient engaging in the tasks of treatment, I know I've got a better shot at later kind of hooking them in and increasing their motivation to engage. But again, remember the panda and the bamboo. So sometimes even with rewards for our patients who are really selective, it may not do anything. And it might be that we have to sort of take almost like a harm reduction approach. Like, are there things that we can do at least to try to keep this patient intact nutritionally and to keep their health intact? Like, could we just add a supplement? Like, even if, right, they're eating like 3 foods and they're drinking like 2 or 3 supplements a day, that's so much better than them just eating 3 foods, because we've rounded out their diet in a way that's going to protect them from nutritional disease. Another in that I sometimes have with those patients is like, all right, we don't have to worry about your eating. You can keep eating the way you want. I'd love to change your eating, but if you're not willing to do that, but are there other things that bother them? Like, maybe they don't want to change the way that they eat, but they still feel embarrassed about eating that way in front of their friends, or they like still can't go out to eat with their family and they'd like to be able to go out to eat with their family. So are there things we could maybe work on there that don't require us to change their diet? So could we work on like helping them manage their anxiety in social eating situations? Could we work on other ways to like increase their self-confidence? So those might be other ways to make a difference, or like kind of a back door for getting into treatment with those patients. And then sometimes at the end of the day, I just recommend time. If it's an older teen, I'm less likely to recommend time, simply because I think kind of like our developmental windows are closing, or like I think the longer ARFID goes on, the more rigid those preferences become and harder to change. But like sometimes if it's like a younger patient who's maybe like preteen, I say like, let's come back in a couple of years. Like, let's come back when they're later on in middle school or when they start high school, because those social pressures might force them into it. But we also know that our bodies change and respond to puberty and respond to time, and adults in general are more able to tolerate a wider range of foods and preferences than kids are. So like maybe with time, their preferences might shift. Final thing I'll suggest is that sometimes maybe we can shift the goal away from like expanding the diet and just focus on trying things. Because again, if I can get a patient to just try stuff, then I know that window will always be open for them to discover a new food that they might like. Whereas if that window is never there, they're much less likely to ever find things that they might expand their diet to. So my summaries are, can we bring on rewards, some sort of thing to enhance motivation? Or could we shift the focus? So if the patient is just really resistant to touching dietary expansion, let's do some harm avoidance, or like let's do some harm reduction by bringing in supplements that would protect the patient's health. And then let's shift the focus or the goal of treatment and see if we can find like kind of a side door or a back door in.
Incredible answer. So thorough. Thank you. Well, we are out of time. I just want to respect everyone's time. I know there was questions that didn't get answered. So if you would like to email me them, I could always pass it along to Equip and get the answers. Thank you so much. That was so great. I wish we had more time to hear more and get through all of these, but we appreciate Equip and Dr. Menzel for being here and for presenting to us. Thank you again.
Great. Thank you all so much. I really appreciate it, and awesome questions. Well, hope you all have a wonderful weekend.